On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce Dr. Maisha Robinson, neurohospitalist and director of palliative care medicine at the Mayo Clinic in Jacksonville, Florida. Dr. Robinson also has an interest and is published in health services research and healthcare disparities in racial and ethnic minorities. And Dr. Robinson, I've been really looking forward to talking to you. First of all, the timing is perfect because there's all this new data coming out about healthcare disparities with COVID-19. So I definitely want to talk to you about that. But maybe we could start off by talking about the unique challenges that COVID-19 brings to the practice of palliative care medicine and kind of, what neurologists who are going to be caring for COVID-19 patients and navigating these, treacherous waters, maybe some tips and some pearls.
Yeah, well, thanks so much for having me. Just to maybe start off and talk about what palliative medicine is. So
Right.
Palliative medicine is a specialty that focuses on trying to recognize, prevent, and alleviate suffering of all forms in patients that have serious or advanced medical conditions. And many of our patients that have neurologic disease fit into that category. And so while there's a specialty that focuses on that, all neurologists essentially are doing some degree of palliative medicine just by the nature of what we do. We're all trying to optimize function and try to get our patients doing as well as they can for as long as they can. So when we think about COVID-19 and palliative care, we certainly find ourselves in an extraordinary circumstance right now. And people often think that palliative care doctors are in the room only holding hands and hugging people and, singing kumbaya. But we're actually uniquely tailored to this type of time. People say, can you do palliative care virtually? And the answer is really yes, it can.
Right.
Our procedure is the discussion. And so even though we are now doing so much teleneurology and doing video visits or phone calls, we have a unique opportunity really now to have high quality goals of care conversations with our patients. So much of what we're hearing in the media, in the news is about, how do we prevent the virus from spreading? And I think that's very important. But also, I think there needs to be some focus on, for the people who actually have the virus, how do we discuss what their values are, what their preferences for care are, particularly in a high-risk population, people that are at high risk of morbidity and mortality. And so I think there are communication guides available that are quite helpful. There are shared decision-making tools available that are quite helpful, but really sitting down and trying to get to know the person, get to know your patient on a little bit of a different level, and asking, if you were to get this condition, and if you did not have a mild course of it, what would you want based on what we know is important?
And it's, I've talked to colleagues of mine and you may have read some articles online about, residents out there, attending physicians that are literally before they go to the hospital, they're writing their wills or putting together their living wills and their healthcare surrogates. I'll be very honest and frank. I did the same thing. I went to LegalZoom, not trying to be promotional, but literally I went and I literally did all this. I've never done that before. And this is the first time, we have a 4-month-old and I've never talked about this stuff with my wife. And I said, wow, we better talk about this stuff. And in terms of goals of care, I said, yeah, I want everything done. I'm ready. And then my wife said, well, I want everything done, but I don't want ECMO and I don't want this and I don't want that. And these are really important conversations to have. I mean, if you're a physician, you're going to go a little bit deeper, but for the public, I guess, how should a neurologist approach this topic? And what tips do you have? Because, when someone is sick, but not horribly sick, but something with COVID, people can go downhill pretty quickly. What are some tips? Because this is a tough thing to talk about. I have a family member that's ill and in the ICU with COVID. I mean, I don't even feel comfortable talking to a family member. What tips do you have for a neurologist, and especially a neurologist providing care via video rather than in person?
So first of all, thank you for offering a little bit of your experience with getting your own advance directive completed. Yeah. I think that the first step would be actually to encourage our colleagues to think about their own living wills and identifying their own healthcare surrogates. Going through that process allows you to be readily conversant about it, and also allows you to feel a little bit more comfortable in talking about it because you know what that experience was like having to think about it. So I have mine done too. And I tell my patients that all the time. I'm relatively young. I think I'm healthy. I don't think I have any serious medical conditions, but anything could happen to me, including a significant case of COVID.
Right.
And I want to make sure that people are not guessing what I would want. I want them to know who to call. So I have a healthcare surrogate outlined plan. I have a living will done. I want those healthcare surrogates to know what I would want and what I would not want if that time came. And I'd say to people, so it's really my responsibility and a privilege to really get to know you and to help you complete that as well. Right. So I think the focus is so often on people who are critically ill when we try to get these documents completed, but they're called advance directive for a reason. They're supposed to be done in advance of when you need it, not in the intensive care unit, and not necessarily when people are hospitalized. So this is the time to be talking to our patients about it. And because of the pandemic, this is a nice, I think, jumping off point. Given everything you've seen in the news, given everything that you've heard, I know that people are now talking about these living wills. Is it okay if I talk to you about that some?
Great. That's great. When I was doing all the paperwork, I guess I was like, okay, if something goes, because I was coughing, I wasn't feeling that great. I was okay, but my fever, I said, you know what, let me get this in order. And I started doing it. And I realized, wait a minute, you kind of can't do this all like immediately. Some of the forms you need a
notary.
A notary, exactly. Yeah, you need a notary. Another form, you needed 2 witnesses to sign it. Otherwise, it's not valid. And then I was reading online about probate, and I'm just like, oh my gosh, there's all these legal things. So, preparing in advance, that's a great point. It's an advance directive for a reason. So that's really helpful. That's great. When it comes to COVID and just the fact that you can kind of be a little sick and then, 6, 7, 8 days later, just, a rapid decline. And I guess you have some ways to prepare, but what are some of the unique challenges of COVID? It's a new disease, it's a new condition. So, it's not like, cancer, for example, when you kind of know that you have a prognosis of, X number of months or years, and you kind of know what it's going to be like. And you can give, reasonable, not perfect, but reasonable predictive estimates about prognosis. When it comes to COVID, no one knows anything for sure. What are some of these unique challenges, and what can neurologists be prepared for?
So I think what you described is really one of the big challenges. When I talk to patients that have neurologic conditions, I am able to draw out the trajectory of disease usually. Yeah. Is it a neurodegenerative process? Is this a neuro-oncology patient, et cetera? But with COVID, we just don't know, as you mentioned, what that trajectory is. Right. And so it's challenging to try to tell people this is probably how the course will go. And this is kind of when we need to start thinking about this, and this is when we start thinking about this, et cetera. And so knowing that it is unpredictable, you really have to talk about everything up front because you're not sure about how the trajectory is going. So I think that's one of the first challenges. I think the second challenge would be with the understandable change in institutional policies and accommodations that have had to be made because of the pandemic. Patients are in the hospital without loved ones. Right. And so this is an unusual time because patients are having to make decisions independently, or we're calling family members, caregivers, healthcare surrogates to help make decisions for people that perhaps they saw walk into the hospital. And now we're calling to say, they're intubated, they're sedated. What is your understanding of what we should do right now? And so we've been creative about how do we connect patients and families virtually. We've also had to figure out how do we keep people informed on a regular basis and more up to date. We've taken for granted the family members being at the bedside. And so this has been a challenging time, but it's caused us, I think, to think outside of the box a little bit so we can provide the needed information to families. I think the third challenge is really thinking about the patients that do not have COVID, but are still impacted by everything going on. And many of our neurology patients are used to coming to see their neurologist in clinic. They're looking forward to getting physical therapy. They're used to, family members are used to having care providers coming to the house and support friends, families. And so many of our caregivers are finding themselves at home alone with somebody with dementia or ALS. And we have to think about the caregivers and ensure that we're providing the kind of support that they need, or as much as we can, whether it's through a virtual support group or asking social workers to contact them, or if we're just calling to check in.
Yeah. This no visitor policy, when I heard that this was going to be the rules and then it spread kind of throughout, and it made a lot of sense, don't get me wrong. But then I heard the horror stories and just the sad, terrible, I have a good friend of mine, Dave, his aunt was pretty sick, and she was pretty ill and wasn't very healthy, but, then got COVID on top of everything else. And the family had to make a decision that they would rather the patient die at home than take to the hospital, even though they have a higher chance, she would have a higher chance of living, but that they didn't want to be apart because no visitors, dying alone was too terrible. So that's the decision they made on Monday night. And I took a step back and I said, oh, what a traumatic situation. What a terrible decision. I mean, these types of conversations are going on all over the country. It's, oh boy, I don't even know how to, how would you even counsel a family on something like that? Or are there just not easy ways no matter what?
So one of the, I think, benefits of having those types of conversations, very real, raw conversations with family members is, where do you want to be given what we know is going on? Now, certainly some people are going to need to be in the hospital. They have courses that are declining, and there may be some medical technology equipment that can help improve their overall trajectory, being in the ICU, being on ventilators, being on dialysis, et cetera. But then there are some people that we know have chronic medical conditions who would perhaps not benefit or who might not want those types of medical care. But hospice care is something that I think could be broached with somebody who thought, I want to be at home, I want to be with my family. Most hospices are still enrolling people during this pandemic. And so they're able to come out and assess the person and ensure that they have the needed care, particularly at the end of life. So social workers, spiritual support, nursing care, physician. And so you have a whole team at home, not only providing care to the person that's dying, but also to the family.
Gotcha. And, these videos are intended for our 36,000 members of the American Academy of Neurology and readers of Neurology Today. But the videos are also posted on YouTube. So I think we've been getting a lot of members of the public watching these too. So could you just define hospice and what hospice care is, the philosophy of hospice care? I'll be very frank. I mean, I'm a neurologist. I should have been trained in this stuff. I really didn't fully understand hospice care until probably a few years after I was done with my residency and fellowship training. How would you define hospice care?
Yeah. So many people equate hospice with palliative care.
Mm-hmm.
And we like to think of it as more an umbrella term.
Yeah.
So palliative care focuses on trying to improve quality of life for people that have serious or advanced medical conditions. You often hear people say at any age and at any stage, palliative care is appropriate. Mm-hmm. Hospice care is a type of palliative care. So it's under the umbrella of palliative care, but it's specifically for people who are near the end of life. Usually if prognosis is 6 months or less, then somebody is hospice appropriate. And so not all of palliative care necessarily means hospice care, but hospice care is palliative care specifically for people at end of life.
Great. Okay. Super helpful. So let's switch gears a little bit. We have a little bit of time left. And, I read a story on ProPublica like a week ago. I think that's when we reached out to you. And then literally in the last 24 hours or so, there's been an explosion of data on some things that I guess maybe aren't. I'll just be honest. I was surprised by the numbers. I'll be honest. And the numbers are, just as an example, in Chicago, 70% of people who die from COVID are African American, but the city's population is only 30% African American. In Milwaukee County, similar thing. 27% of the population is African American, but 81% of the deaths. Similar statistics in Philadelphia, Detroit, other cities. And as COVID-19 sweeps across our country, especially, over the next 2 weeks during, who knows exactly when the peak is going to be, but it's coming. How do you really rationalize, or how do you think about these widespread disparities? And I guess that what worries me is that, our federal government and most states just aren't really releasing demographic data on race or ethnicity of people who've tested positive. They aren't releasing yet, that I've seen, numbers on deaths, age ranges, ethnicities. How do you make sense of this? And what do you think neurologists and APPs and other members, how do we interpret this, and what can we do to, ideally improve outcomes?
So these numbers are very concerning. And like you, I've started to see over the past few days, more and more articles highlighting this in specific states and cities. As you mentioned, we don't have kind of global information about this, but for some of us, this is unfortunately not surprising. I think this pandemic is highlighting what many of us have known to be true, that there's significant disparities in healthcare in this country. Some of that has to do with social determinants of health, socioeconomic status, access to care, educational opportunities, transportation methods. For instance, you've heard about some of the people who are riding subways still and driving buses and needing to still get to work during this time, unable to be able to shelter at home. And so I think this is highlighting what many of us have known to be true. I think that this is an opportunity for this to come to the forefront, and we can be proponents of thinking of strategies to try to mitigate some of these healthcare disparities. When we think about disparities in end-of-life care, disparities, I think also with regard to, for instance, development of some of the neurodegenerative conditions, stroke, and I think neurologists have an opportunity to say, these are my patients. We're worried about this risk of COVID, but not only that, we're also worried about some of the other disparities that we face every day.
Yeah. And, I've been watching, I'm sure like most of the population, watching a lot of news stories and, television and reading online. And, I hear a lot, without data, we need more data. We need more data to make decisions. Well, when it comes to, disparities with COVID-19, now we have the data. So now we have to come up with a plan. And I don't know, these numbers are shocking. And I hope, I hope we figure out ways to mitigate this. Not just the disease in general, but the disease impacting very specific communities in specific ways. I'm not sure if you saw. There was a bus driver in Detroit who he put out a video on Facebook about there was someone coughing on the bus, and just that that video. I mean, it brought a little bit of a tear to my eye, but that video and people speaking out and just trying to educate people that this disease can be really bad really quick. And you're right, certain populations are taking public transit more frequently. Other populations are maybe more wealthy and maybe not using public transportation or can afford to stay home rather than work. So I think, whether it's a genetic, for example, I'm an Alzheimer's specialist, and Alzheimer's affects African Americans and Hispanic Americans at much greater rates than Caucasian Americans and other ethnicities. And, is that because it's a genetic thing? Is it, other areas? I think we really have to study how COVID-19 and why, and then only then can we, truly make changes.
I agree with you. And I think that video put a face and a name to what we have known, because numbers are one thing, but I think hearing the stories really compels people to act. And so we hope that we will see some changes in the near future.
Exactly. And if anyone's watching, hasn't seen the video, you can Google it. It was impactful. It was strong language, but it was required. I mean, it was necessary, and it was, it was raw, and it was real. So, Dr. Robinson, absolute pleasure. I learned a lot. Thank you so much. And to those watching, if you're interested in very specific topics or have ideas, just shoot us an email at elearning@aen.com, and we'll do our best to get it out there. Maisha, thanks so much. Appreciate it.
Thank you so much. Have a good one. Bye-bye.